I'll share mine just to check. Is it visible?
Yeah, perfect.
Okay.
Is it better now? My voice and video?
Yes.
Yeah, better,
Yeah,
but
this is better.
still there is some lag.
Okay, okay. Because I've connected through my phone, so probably I'll have a better network. Anyway, in that case, I might switch off my video so that the audio goes on seamlessly. Hi, good evening, Dr. Arnab.
Good evening. Good evening,
Dr.
Dr. Sushil.
Hi, hi.
Can you hear me?
Yeah, you're audible, visible quite comfortably. If you want to try this slide share, if you want, we'll just give it a try.
Actually, I don't really have any slides to share, so
Okay, no problem. No problem.
I'll just be chairing the session. So
Absolutely, no problem.
sure.
Is my audio video clear? Because there was some issue earlier with my network.
No, I can hear you perfectly well, and I can see you as well.
Great, thanks.
Yeah. So we're starting at 6 on time.
Yeah, we'll start at 6.
Okay.
Hello.
Good evening, Dr. Abhishek. Can you hear me?
Yeah, I can hear you. How are you doing?
I'm fine, thank you.
I think we're still waiting for Dr. Arun Prasad.
Yeah, looks like it.
Dr. Raj Paneliyappan is joining in a while, maybe 2-3 minutes. I just had a word with him. Namaste, Dr. Arun. Would you like to test your audio, video, and slide share, please? Namaste, Dr. Raj.
Hello, hi.
Yeah,
Good evening.
your audio, video is clear.
Yeah.
Is it clear to everybody else also?
Hello, Raj.
Hello, hi. How are you?
Very well, very well.
Okay, that's good. Yesterday, only one of my I'm mentoring one guy by name Dr. Shashank. I think he's coming to you sometime
Oh,
in
Shashank
February,
Shah,
March.
yes. Yeah, Shashank Shah, he's coming. He was supposed to come last year and then he couldn't because of COVID
Yeah,
numbers.
yesterday I went to help him with the bariatrics. He was telling me that he's coming and meeting you.
Yes, yes. It's just coming before OSICON.
Yeah, that's right.
Hi, Arun.
Hi, hi,
Hi, Dr. Arun.
hi, hi,
Hi, Abhishek.
hi, Raj. Hi, Abhishek. Hi, Chetan.
Hello, you okay, Arun?
So, namaste everyone from Gapio. It's 6 o'clock. So, will we go on tracking? We should start the session.
Sure. Okay by me.
So, I'll request Dr. Raj to carry forward the session. Thank you.
Hello, hi. So thank you for trying to work on various exercises with regards to the surgical aspects. And we had robotic before, and now we are having a bariatric one. And we have one of the eminent Dr. Chetan Parma from UK, who's going to give us a good insight into the various bariatric surgeries. And of course, Dr. Arun Prasad, our ex-president and the guy who really helped us juniors to grow big in the field of bariatric and robotic surgery. And he's been still being a mentor for a lot of young students. And Dr. Abhishek, my colleague, and we are all in the second phase of the bariatric group in India, where we were youngsters before, and now we are in the senior group. And he's been with AIG Hyderabad and doing a lot of wonderful work, including endoscopic and laparoscopic bariatric surgeries. So we would like to proceed further with the program. And I would like the faculty to introduce themselves, and then we'll go ahead with the session. Dr. Chetan.
Hello, good day, everyone, whichever part of the world you are in. I'm Chetan Parmar. I'm one of the bariatric consultants working in UK, and I'm part of the British Obesity Society Council and chair for the annual scientific meeting, and also the ALS GBI. I'm part of the member of the MGB OAGB International Club. I'm editor to few journals, and I've written maybe more than 150 papers now in few book chapters. And thank you. It's a pleasure and honor to be here, to be honest. And thank you, Gapio, and thank you, Arun, Raj, Abhishek, and all for the kind invitation. Thank you.
Yeah. Dr. Arun Prasad, please introduce yourself.
Hi, I'm Dr. Arun Prasad. I'm a senior surgeon at Indraprastha Apollo Hospital. I do GI, bariatric, and robotic surgery. I was formerly the president of Obesity Surgery Society of India, currently the president of the MGB OAGB Club, which I run along with Chetan. And it's a great pleasure to be part of this Gapio series. And we are also endorsed, and we do this jointly with ARIS, which is the Association of Robotic and Innovative Surgeons in India. So I look forward to an excellent session, and I'm looking forward to the talks by my colleagues. And it's always a learning experience in these situations. So thank you very much. Over to you.
Dr. Abhishek.
You're on mute, Abhishek. You're on mute.
Hello, thank you, Chetan, for reminding me. I'm Dr. Abhishek Katakwar. I'm a bariatric surgeon at AIG Hospital, Hyderabad. Most of you might be knowing Asian Institute of Gastroenterology for the kind of GI work we do, but now we are into everything. And I've been associated with AIG since 2015, and we have set up a Center for Obesity and Metabolic Therapy. And I'm part of many academic activities, part of OSCE Executive Committee, along with everyone here. And looking forward to have a good discussion here. Thank you, Dr. Arun Prasad and Dr. Raj, for inviting me here.
And now we go to the chairperson, another senior consultant, Dr. Arnab Mohanty. Dr. Arnab, good evening, and please introduce yourself, Dr. Arnab.
Good evening. Hi, I'm Dr. Arnab. I'm currently working at Primus Super Specialty Hospital, Chanakyapuri, Delhi. I'm heading the unit of gastrointestinal, minimal access, and metabolic surgery there. So I'm honored to be part of this discussion, and thank you for inviting me to chair the session. I'm looking forward to it.
Okay, and
thank you.
It's such a eminent faculties around. I think we are going to be a big treat now with this session. Let us start the session with a very interesting topic on why diet fails in morbidly obese by Dr. Abhishek Katakwar from Hyderabad. Over to you, doctor. You are still mute. You are on mute, Dr. Abhishek.
So is my screen visible?
Yes, it is.
Okay. So first thing first, why diet fails in morbidly obese patient despite of best possible efforts. So I'm going to cover some of the part which you might have already seen or read somewhere, but there are a few things which I want you to really concentrate. These are the keywords which might help you in your practice also when you talk to somebody who's suffering with obesity. I don't know why my slides are stuck. Okay, so you know what is the biggest preventable cause of cancer after smoking? In fact, I would say preventable cause of death after smoking, and there is no doubt about it. It's smoking, and after smoking, it's obesity, which is the second leading cause of not only cancer but the mortality also. And when we talk about in general practice, you might see a lot of patients walking into your OP clinic. Some of them may be overweight, some of them might be obese, but most of them may not recognize the disease which is associated with obesity. Some of them might have tried different methods for weight loss, but none of them actually work for long term. Some of them might have sleep apnea, some of them may have drowsiness or work pressure. Some of them may be hungry most of the time, they have sugar craving, disturbed menstrual cycle. And obviously, when we talk about obesity, the associated problems like thyroid, PCOD, cholesterol, fatty liver, it comes as a package. Some of them may be diabetics also. And when they talk to you, they ask you how to lose weight. So you, most of the time you might say, okay, lifestyle modification, lose weight. It's, having said that, it's very easy for us to write down, lose weight, improve lifestyle, but it is the most difficult thing to follow. It is like telling somebody to reach a destination, but you don't know how to reach there, which makes journey itself more difficult. So some of the patient might come back to you with your lifestyle modification advice, which you wrote on a piece of paper, and they might say that initially I lost weight because I was very much motivated with diet and exercise, but now it is constant, no matter how much efforts I put. And it's really frustrating because I'm not losing any grams or any inches now. And obviously, when we look into the society, weight has a lot of stigma because, you know, when somebody looks at you, the first impression is like, oh, if somebody's overweight or obese, then probably they may not perform well. They might have, you know, people might have a lot of judgments about them. So it carries a lot of social stigma and it causes a lot of effects, not only to the personal life, but also to the social life, psychological behavior of the person. Now, I want you to concentrate on these keywords, which I will be covering in next few slides. One is the compensatory behavior when you are on diet and when you are doing exercise to lose weight. The term metabolic adaptation also has gained a lot of attention nowadays. Then we'll be talking about weight loss plateau. And obviously the last thing is set points. All of us have read this law of thermodynamics, energy in, energy out. So this is what we thought about obesity, that energy expenditure is a problem. The amount is consumed and the amount which goes out. But that was a concept way back, but it doesn't stand true in today's time, because we know that obesity is not because of the energy imbalance. There are so many things which happens which lead to obesity. It could be metabolic derangements, it could be hormonal imbalance cascade, it could be genetic polymorphism, it could be physiological or environmental triggers, the behavioral factors, the sedentary lifestyle what we have today. To understand all of these, we should know the concept of metabolic rate. Now, when you look into this slide, this is a total thing, the components of total daily expenditure, which is there, out of which the non-resting energy expenditure, which includes exercise activity thermogenesis, thermic effect of food, and non-exercise activity thermogenesis. But the major portion is resting energy. which is in the form of basal metabolic rate, which is resting energy expenditure. In a normal circumstances, this is what it looks like. But I'll tell you at the end, if the time permits, I have a very good video which I would like to share with you, which explains about what happens when you're dieting, what happens when you're exercising and you want to lose weight. There is a shift in your basal metabolic rate. Metabolic adaptation, it's very easy. You can look in the diagram. It's one of the easiest thing I've come across, and I'm still trying to figure out what it looks like and what it wants to convey. But to make it simpler for you, metabolic adaptation is something which happens over a period of time when you're trying to lose weight. And what does it causes? It causes some cascade. When you are energy deficient, you lose your body mass. And when you have this, your body undergoes some kind of adaptation to overcome the thing. And to give you a simple example, I'll tell you something. When COVID came and the lockdown was announced, the whole world, the first thing what we started doing was we went to the grocery stores, we picked up whatever is needed or whatever is not needed. We just put everything, we try to store as much as possible. So this is what happens when you are trying to lose weight by diet and other things. Your body goes under some kind of defensive mechanism and it tries to store more energy in the form of fat. And this what causes more obesity when you are on diet. A lot of my patients, they come to me and tell that, doctor, I'm trying level best, but I think I'm gaining weight by even drinking water and by inhaling air. This is what the example they give. And this is all because of the change in hormone, the anabolic hormone, the satiety hormone, the thermogenic hormone. And this cascade causes increase in orexigenic hormone, which are nothing but the hunger hormone. And what is the impact? Chronic fatigue or fogginess, insomnia, poor sleep, sweating, anxiety, irritability, depression, digestion problems, and craving. These are all the effects of this metabolic adaptation. And eventually one fails of doing the same thing every day and then go back to where they were before, going back to where they belonged. So the fact is, dieting and exercises reduces your metabolism. I'm talking about obesity. It increases your hunger and craving. Also, with an increasing age, your metabolism slows down. We all know that losing weight is anti-natural, so body goes into that defensive mechanism. And when we talk about the set points, brain, the hypothalamus has set point for everything like temperature, hunger, satiety. There are centers for everything. And over a period of time, when somebody becomes obese, these set points are set at the higher level. So they don't feel satiety at a certain level. They need more food to have that reward phenomena. And eventually the set points are set higher and higher and higher. And this is how a person become overweight, and continuously gain weight over a period of time. The best example of this is the Biggest Loser series, which was in UK. And look at this guy, Danny Cahill. He was 195 kg when he joined. He came down to 86 kg. And this was in 2009. And by the year 2016, he came to 132 kg. And eventually he had to undergo bariatric surgery. Not only him, but 80% of the contestants were at the same level after the series was over. So how does it happen? Why somebody, this cascade or the chain reaction doesn't stop? One of the biggest culprit is the insulin. When we have high insulin resistance, which means that you have high fasting insulin in blood, high C-peptide levels, it causes brain fog, it causes belly fat, it causes bloating, it causes sleep after meals, it causes increase in blood pressure, cravings, hunger. You have dark pigments, acanthosis nigricans, and you have hunger between the meals. We all know about insulin resistance theory. So this is what is one of the culprit. I cannot go into the detail of each and every aspect looking at the time I'm appointed, but this is how you can talk to your patient when we talk about obesity. So is there a way to reduce insulin resistance? Yes. What I have found is intermittent fasting, not for diabetics, can help to some extent, but not in people who are already obese. But if you're overweight, yes, definitely it can help to some way. The second thing is high potassium food because it enhances the insulin response. Vitamin B rich food, and obviously high fiber diet. In fact, a lot of people had their conversation about the fat, but ghee is one of the substitute which can release energy over a period of time. So ghee or fat is not the problem. The problem is calorie food. The problem is sugar. Low cortisol, stress, and estrogen can also improve that. Obviously, you need to have a good sleep, exercise. Now, if nothing is working out, the final answer is if I would like to share this.
We have this idea that if we want to lose weight, we join a gym on January 1st, we start working out regularly, and eventually we slim down. Well, here's some bad news.
We need to rebrand exercise. Exercise isn't a weight loss tool per se. It's excellent for health. It's probably the best single thing that you can do other than stopping smoking to improve your health. But don't look at it as a weight loss tool.
Exercise will definitely help you live a longer, happier life. It's just not the best way to lose weight. And the reason it has to do with how our bodies use energy. There are three main ways our bodies burn calories.
These include your resting metabolism. So that's how much energy your body burns just for its basic functioning, just to keep you alive, basically. The other part of energy expenditure is the thermic effect of food, and that's just how much energy is required to break food down in your body. The third part of energy expenditure is physical activity.
For most people, physical activity, that's any movement you do, only accounts for about 10 to 30% of energy use.
So the vast majority of energy or calories you burn every day comes from your basal or resting metabolism, over which you have very little control.
While 100% of your calories in are up to you, only about 30% of your calories out are in your control. For one thing,
so if nothing works, then we have to look for bariatric and metabolic surgery, which my colleagues will tell you in next few slides when their talk come. But compensatory behavior, I focus one point. When you might have also noticed that when you go for gym, you tend to take stairs sometimes, but most of the time when you are coming back from the gym, you take lift because that's a compensatory behavior. You go to gym and then obviously post gym, you tend to eat more calorie rich food because that's a compensatory behavior, which is nothing but because of this excessive response from the body. So I'm okay with any questions if you have. I wanted to finish in time, so I rushed.
Thank you so much, Dr. Abhishek. So as Dr. Abhishek has said, they always say that weight loss by diet exercise, since the mechanism based on three aspects. One is a homeostatic function, hedonic function, and third is executive function. So the homeostatic function is for eating for hunger, and hedonic is for pleasure, and executive function is desiring to eat. That's what we say, that if you have food in front of us or suddenly you wanted to see, so we see food and eat. So what happens is the homeostatic function, they always say it's not in our control, which is the major, they say around after 250 gene mutations that happen with obesity, more than 130, 140 are because of the homeostatic mechanism, which the nervous system control. So if, as Dr. Abhishek said, if weight loss happens, it's against nature. So the homeostatic mechanism takes over and it spoils the whole fun. It increases your hunger. So the energy gap becomes higher in the sense it increases your hunger, stores all the fat, stores all the calories, and reduce the expenditure. So that way the energy gap becomes much wider. So homeostatic mechanism will not allow you to really help to lose weight by diet exercise alone. So it has to change at the genetical level. At least you have to change at the genetical expression. So that is where genetical expression is very important, and that's why the lifestyle changes big time, helps in trying to control the hedonic system and the expressive function. So when the expressive and hedonic function 2 comes down, again, in a span of 1 month, 2 months, body will try to adapt itself and homeostatic takes over. And that is why a lot of these people fail. And that is when a bariatric surgery really helps, because the gene expression changes. About more than hundreds of gene expression changes. And that is why we are really helping our patients with bariatric surgery. With that in mind, Dr. Parmar, Dr. Arun Prasad, do you have any opinion on this? Or our chairperson, please, doctor, do you have any opinion on this?
Yeah, my talk is actually opinion on what you are saying, and it will be continuing on what Abhishek is already said. So I'll pass that question for now.
Okay. Dr. Arnav?
Yeah, I would just like to add that often when we see patients in our outpatients in the metabolic department, we see that many of them are of the opinion that they want to avoid surgery, and we see a lot of referral systems which are in place which would refer the obese patient to various departments, such as to ENT for an OSA surgery, and they're going to orthopedics for arthroplasties. But very few referral systems are actually in place, especially when we speak of India, where obesity is not yet being looked at as a disease in itself. People are treating diabetes, hypertension, OSA, and everything else around it. But tackling the main problem of obesity is not really in vogue so far, if we move to tier 2 towns or avoid the metros especially. So I think proper counseling and a deep referral system is important. And when the patient comes to us, probably the first question that needs to be tackled is the first topic of the day by Dr. Abhishek, which explains why diet and exercise, which is commonly put forward by the patients or their attenders, that shall we not try this first? And we need to be aware of why that is not a likely successful option for them. So when we have managed to convince a patient that that is not probably going to work out because it is beyond a sedentary lifestyle, it is beyond an indulgent lifestyle, or even heredity, which is causing the obesity, it is a problem which needs to be surgically tackled. And then we move on to, explaining the physiology behind the procedures that are a myriad available actually. And because there are so many available, it is very important to know how the physiology of each procedure, whether it's endoscopic or a balloon related, or a laparoscopic procedure, whether it is a restrictive procedure, a malabsorptive one, or a combination of these. So it's important to understand the physiology behind each of these, which is not discrete to each procedure, but there's multiple overlaps. And with the thorough understanding of the physiology, we would be able to explain and tailor a particular procedure to our patient's need, rather than follow a single type of procedure throughout our career, which suits us or is logistically more acceptable. So I think we would welcome Dr. Arun to share his views on the physiology behind all the different types of procedures, so that we can counsel our patients with better understanding. Dr. Arun.
Thank you. So a few words on physiology of bariatric and metabolic surgery. So this is a very typical sort of a picture, similar to what Abhishek also showed. And this talks about insulin and how insulin promotes glucose uptake. And insulin is what opposes the hepatic and glycogenolysis and gluconeogenesis. So when we have a situation of insulin resistance, then that is going to lead to more resistance and obesity. And when you get obese, you'll have further resistance and it becomes a vicious cycle. So how does this work? What we call as diabesity, obesity leads to insulin resistance leads to high blood sugar. High blood sugar again causes high insulin levels. High insulin levels lead to obesity, as we saw in the mechanism, whereby high insulin level is going to lead to fat deposition. So India has a big problem, and we are constantly increasing the number of diabetics in our country. And something which is very concerning is that 25% of the obese children in our country are going to grow up and become diabetics. So it brings us to a terminology which is known as incretin. So what is incretin? Incretin are gut-derived factors that increase glucose stimulated insulin secretion. So the short form, incretin, intestine secretion of insulin. So let's spend a few minutes on this slide here. What you see on the left is the response of the venous plasma glucose to oral glucose and IV glucose. So if you see again on the left, when you give someone oral glucose, the plasma level in the vein, venous plasma glucose, it goes up and then it comes down. Green is the oral glucose. When you give IV glucose, again, the venous glucose level goes up and comes down. But what happens to insulin? So now if you look on the right side, you will see that when I give oral glucose, the C-peptide level goes up and comes down. But when I give IV glucose, there is not much of change in the C-peptide levels. So why are we talking about C-peptide? See, the problem is that insulin levels are not easy to measure and they can be fallacious. So if we go a little bit back to our biochemistry days, the pre-insulin molecule divides into C-peptide and insulin. So C-peptide in the blood is going to give exact idea as to what the insulin levels are. Hence, we are using C-peptide. So what you saw on the right is that the oral glucose causes C-peptide level rise, but the IV glucose does not. Whereas on the left, both oral and IV glucose lead to a similar rise in the blood glucose level. In other words, the glucose that is going through the gut is causing a rise in C-peptide, but the glucose that is going through the veins is not causing a C-peptide rise, and that is known as the incretin effect. So once we have understood the incretin effect, let's look on the left side, which are control subjects. Now here you see that the insulin level goes up with intravenous, with the oral glucose, but it does not go up with IV glucose. And on the right side, you can see how that gap has got reduced, where the rise of insulin has been reduced on the right side. And this is what happens with patients of type 2 diabetes. There are enterohormones. We've heard these names before: GLP-1, GIP, PYY, oxyntomodulins, cholecystokinin, ghrelin. There are various hormones. Ghrelin, which is the last one, is responsible for satiety. So when we talk about GLP-1, so GLP-1 is secreted upon ingestion of food. It enhances the glucose-dependent insulin secretion, which you see, promotes satiety, reduces appetite, reduces postprandial glucagon secretion, reduces the glucagon hepatic glucose output, and helps regulate the gastric emptying. So in other words, the GLP-1, it increases the beta cell response, as you can see on the right, and it reduces the workload of the same beta cells. And that is how GLP-1 helps in getting the metabolism back into place. So when we talk about obesity management, we are talking about weight control, protein, carbohydrate, exercise, cardio exercise, medications, metabolic surgery. So the role of medications again is related to the mechanism that I just spoke about. And so we'll skip the top few because they are not part of today's meeting. There are certain weight loss drugs that have been approved. Of this, the last one has been in news for many years till recent times, and that is liraglutide, comes as Saxenda and Victoza. They are there for control of diabetes at a dose of about 1.2 to 1.8 milligrams. It's given as an injection. For weight loss, it starts working when given at the dose of 3 milligrams. It has to be gradually increased because it has its own side effects of nausea, vomiting. The newer one, which has come also of great interest, is semaglutide. The tablet is known as Rybelsus, and we also have injections in the form of Ozempic. So these are also working on the similar mechanism and have shown promising results. There are studies. So this is a study of semaglutide, and we are all eagerly waiting for the results as to how this can help in obesity management, both primarily or as a combination with a bariatric procedure, or even as an offer to people who have regained weight after bariatric procedures. Last we come to metabolic surgery. Now, of the medical innovations, now this was 2013. And of all the medical innovations that have happened in recent times, it was found that bariatric surgery is one such main innovation, and it came in the top 10 list. There's this great article which everyone refers to, which had compared regular treatment with bariatric surgery. I'll come to that in a while. Then we have a gastric balloon, whereby we put a balloon inside the stomach, and this leads to satiety, change of eating habits, and patient loses weight. So after the balloon is removed, we hope that the change of lifestyle, the change of eating habits that the balloon had induced, patient is going to maintain that. And if you maintain that, you will maintain the weight loss. So it is a tool that helps. Similarly, we have a procedure known as endoscopic sleeve gastroplasty, whereby we go inside and suture the stomach. We make the size of the stomach smaller, and this suturing of the stomach is going to again reduce the stomach capacity. It leaves a small fundus behind, and that fundus, when it gets filled up, it leads to satiety and feeling of fullness. This procedure is an alternative to surgical procedures in patients who are not fit for surgery, who do not want surgery, or in whom surgery is not indicated. Then the latest technology is that of robotic surgery, which we use especially in patients of super obese, like the one you are seeing in the screen, a patient who was weighing around 270 kilograms. And here the robotic surgery helps us because these robotic instruments make surgery more precise. The 3D vision is there to make us see things better. There is less bleeding, less chances of anastomotic leakage. As you can see, the suturing is done under very sophisticated environments. This is the same patient who shifted to his room an hour later, and in the evening he's able to walk to the toilet because of the reduced pain that happens as the torque is reduced using the robotic arms. He did well, and after a year we had good control. This is the same patient. These are his genes before surgery. After surgery, he kept his genes, but he could fit into one side. Sometime later, he could not use those genes, so he had to buy a new pair of genes. So, metabolic surgery, what do? We manipulate normal organ systems to achieve alteration in physiology, resulting in resolution of disease process and weight loss. So by metabolic bariatric surgery, we are not actually removing the fat or the weight of the patient, but we are altering the physiology and redoing the balance which had got imbalanced, which is something like this. So we have a foregut theory, and here what it says that exclusion of the duodenum results in inhibition of a putative signal that is responsible for insulin resistance and abnormal type 2 diabetes control. So what we are trying to say here is that in the duodenum, there are certain chemicals produced which are anti-incretins. If you remember my incretin slide earlier, and these anti-incretins are going to now get reduced because the food is either going to pass rapidly through the duodenum, like in a sleeve gastrectomy, or it bypasses it completely, like in a bypass surgery. Hence, bypass surgery results are slightly better. And what was done once is that they did a study whereby you put a tube inside the stomach of a pig and saw the result, and suddenly the diabetes became better and the weight loss started happening. Then they did another endoscopy and made holes in the tube. So moment they made holes in the tube, the diabetes came back and the weight loss also got reversed. So that is the foregut theory. We also have a hindgut theory, which says that the more rapid delivery of undigested nutrients to the distal bowel upregulates the production of L cells derivatives like GLP-1. So the GLP-1, which we were talking about in the drugs like semaglutide and liraglutide, is produced by the terminal ileum, and this is naturally produced. So we get a natural production of GLP-1 by bariatric and metabolic surgery, which has both central action in addition to the gut action. That is the reason why the GLP-1 produced by bariatric surgery has no side effects, and it also gets better weight loss, better control of diabetes, and does not taper off with time. So it's talking about early delivery of food to distal ileum and bypassing of the duodenum and proximum jejunum. These are some studies which showed what I've just spoken about, how bariatric surgery gives much better results in weight reduction and diabetes control in the obese. Another study which in severely obese patients, bariatric surgery resulted in better glucose control than did medical therapy. Preoperative BMI and weight loss did not predict the improvement after these procedures. Hence, it shows that it's not the weight loss, but the hormonal mechanism which is working here. That's the graph there. So surgical treatment and metabolic potentially eradicate diabetes efficiently. That's the Stampede trial, where they did laparoscopic Roux-en-Y and bypass and sleeve gastrectomy. And diet and medical therapy versus bariatric surgery in type 2 diabetes, that's the DIVACI trial. So these are the two trials which are commonly quoted. Both showed that surgery was more effective than medical care in resolving or managing type 2 diabetes. So in fact, my bariatric patients who are diabetic, non-insulin dependent, the next day after surgery, the results are visible and the blood sugar goes down and they don't need to take any further control for their sugar, even much before the weight loss starts. So should we predict which are the patients who will benefit? Yes. Why should we predict? Because we should be able to select the group that will benefit. We should avoid patients who will not benefit. We should be able to predict the degree of benefit, predict the duration of benefit, and predict the chances of relapse. So to do this, there are many scoring systems, and all the scoring systems, I'll not go into that. That's part of our surgical talks. So these conclude that patients who are of younger age, males, shorter duration of diabetes, high C-peptide levels to start with, no GAD antibodies, not on insulin, on metformin only, with BMI more than 30 are the ones who would do best when we do surgery for diabetes. So to conclude, bariatric and metabolic surgery works by altering gut hormones and physiology. Insulin homeostasis is the key to success, just like what Abhishek was talking about in his talk. This is just taking that forward. Effectively, it's an endocrine surgery. Artificial intelligence and deep learning is the process to follow to improve outcomes and to predict outcomes. And for what are the current indications and options, Dr. Chetan Parmar would be covering that in his talk next. With that, I come to end of my talk. Thank you very much, and stop the screen share and hand back to Raj.
Thank you so much, Dr. Arun, for a detailed explanation about the mode of treatment and what are the physiology behind each treatment of weight loss. Yeah, I also want to add that there is always a bile salt and the gut microbiota also plays a role. Of course, that all because of the bypass or the malabsorptive mechanism that helps in bariatric surgery. And you said there are a lot of predictions for the weight loss after bariatric surgery. So in your opinion, what would be your ideal choice of bariatric surgery? I mean, ideal choice of patients for a bariatric surgery. What BMI you choose for these kind of patients, and what makes you choose bariatric surgery over endoscopy and medical management? You are muted, Doc.
I think Chetan is going to cover this in his talk, but very briefly, as the BMI goes higher, the endoscopic procedures would not work. And as the BMI goes higher, bypass surgery becomes the procedure of choice. So if you could take a curve, we have the medical management followed by endoscopy, followed by sleeve, followed by bypass. So I follow some such curve. And as I said, I think this is going to get covered in our next talk. So I'll not say more about it.
Okay. So for the delay, let us get to interesting talk by Dr. Chetan Parmar. He will be talking on the current indications for bariatric surgery and the options of surgery that is available right now in the world for us to choose, or maybe having an algorithm to work around. Dr. Chetan, please.
Thank you very much. Thank you, Raj, again. While I'm loading my screen, thank you, Gapio, thank you, Arun, and the eminent faculties. It's a pleasure. And I think my talk has become a lot easier because Abhishek and Arun has made the whole understanding of obesity and metabolic surgery so easy. I think you can see my slide.
Yes, we can.
Yeah, good. And if there is any interruption, please let me know. Thank you. I'm Chetan Parmar. I'm one of the bariatric consultants in London, and I'm here to talk of the current indication and options for bariatric surgery. And as I mentioned, I think few points have been already covered, so I'll try and skip it. And as far as I know, the audience is of more non-bariatric surgeons, so I've tried to put my talk accordingly. Now, why are we having this talk in the first place? I think this is why we are having the talk, because this is what humanity has done to itself. We are at this stage of evolution, and I think it needs addressed soon. When it comes to this, for example, UK, I think obesity rates have doubled in the past couple of decades. 63% of UK adults are overweight, and UK is number 6 when it comes to obesity numbers in the Western world. So that's concerning. And I think what through limelight was the COVID pandemic, where obesity and diabetes were blamed for high mortality and high morbidities and problems. And I think that was one of the, in a way, blessing that it came out and it was in the press and everywhere as well. And one of our leaders was helpful for that as well for a while. And why are we giving this talk in Gapio then? What has India to do with it? As I think Arun and Abhishek already touched up, India is now has the third highest number of people suffering from obesity after US and China. And I think some wise men already realized this a while ago, so they already launched the Obesity and Metabolic Surgery Society in 2002. Asians in particular, why this is a concern? Because we have a genetic predisposition to high body fat percent, also a phenotype predisposes us to central obesity. What is more concerning is that even as low BMI as 22 and 23, Asians can develop obesity-related risk factors. I think this was again picked up by the IFSO Asia Pacific chapter, and they therefore, for indications for bariatric surgery, they had a lower BMI cutoff when it came to Asians. I think India again has a high number of bariatric surgery being performed, as they have their own registry. I think last year itself, another 12,000 were performed. So lots and lots being done there. And I think that's why this talk in Gapio. For some reason, my slide is not moving. Okay, sorry, moving. Now, obesity-related comorbidities. Why is obesity a problem? I think because with obesity, we get a lot of comorbidities which come with it. Diabetes, hypertension, hyperlipidemia, sleep apneas, all the way to cancer, and nearly 13 to 21 cancers now attributed to obesity. So it's a bit of a concern. But why is then weight loss surgery more interesting? Because it actually provides cure to majority of these problems, as you can see in this chart. So let's come to the bariatric surgery indications. These are the NICE guidelines where bariatric surgery is indicated for anybody age of 18 or more. In adolescent, yes, but under a research protocol and under specialized units. For BMI 30 to 35, it should be in patients with recent onset diabetes. For 30 to 35 to 40, patient has to have obesity plus one of the comorbidities. When it comes to BMI more than 40, you can or cannot have comorbidity and you are eligible. BMI over 50, it becomes a first line of option because they are high risk for comorbidities and its associated problems. And as discussed again by everyone, I think for Asians, you can lower 2.5 BMI in all these groups. This is a lovely paper from the Aussie Society here, when Arun was the president. Along with the NICE guidelines, what they recommended, keeping in view the Indian population and the Asian population, that for BMI more than 30, not just diabetes, 2 or more obesity-related comorbidities would be an eligibility for bariatric surgery. In the same way, for BMI more than 27.5, if you have uncontrolled diabetes, you could be eligible for bariatric surgery. So these are the recommendations for those guidelines. And we talked of the Asian phenotype, and we know that they are proposed to central obesity leading to metabolic syndrome. So not just that, they also proposed that waist circumference should be a factor, and more than 80 centimeters in female and more than 90 centimeters in males should be an eligibility criteria as per the OC guidelines. Along with indications, there are always contraindications. I don't think I would go more in detail here. They are quite self-explanatory. Patient need to be compliant, medically fit, no active, uncontrolled mental health problems, chronic smokers, alcoholic, and all are obviously not eligible. It's not safe. Pregnant women and people who want to conceive soon after bariatric surgery are not ideal candidate because they do need to wait. Otherwise, the fetal health can be compromised. So these are the contraindications. So we talked of indications and contraindications. This is something what is practiced in UK, just to highlight that the obesity management starts from tier 3 to tier 3, which is a multidisciplinary intervention. And when that fails in the National Health Service, a patient is then referred to tier 4, or what we call for bariatric surgery in the hospital. So that's how the system works in a Western world. Now, how to lose weight. So we know all this, we need to now find out and talk about the options. Well, there are some easy options to lose weight. One is this. Well, you could measure your weight this way and be happy, or maybe this way and be happy, but we know this doesn't help. So this is basically a sum up of what we have been talking about till now. If you go from the left to right, if you look here, the left is the low risk, you go towards right. So from less effective to more effective, low risk to high risk. We talked of diet and drugs. Arun talked on a bit of pharmacotherapy. Then you go to the right, less risky, less effective, but those are all endoscopic interventions. And if you go towards the bottom and to the right, this is where the surgery comes. So yeah, more effective, but it also involves more risk compared to your endoscopic and drug therapy. Luckily, I think Arun talked on the gastric balloons. So these are gastric balloons we have, which can be put in the patient for 6 months to a year. Patient can lose up to 10 to 15 kilos of weight. They would be eligible for, low BMI or very high BMI who are not for high risk surgery, or they can be even used to check the compliance of the patient. That's how it, a balloon is inserted. It can be endoscopic, where you put an endoscope, put the balloon, inflate 500 to 700 mils, leave it for 6 months or a year, depending on the brand of the balloon, go in, remove the fill-in and remove the balloon. On the right again is what we know as the new balloons, where you don't need endoscopy. You simply swallow the balloon, check the position with the X-ray, and inflate the balloon. At 4 months, the valve automatically degrades and the balloon is excreted naturally. So yes, these are not necessarily bariatric surgeries, but just to give an idea of the options. My slides are sort of behaving a bit odd. So yeah. Now, these are the bariatric endoscopic procedures. I think Arun talked of foregut theory. This is endobarrier, what we know as, where they put a plastic lining in the foregut, and that improved diabetes. However, there were a lot of adverse effects because of this, so the trial was stopped prematurely. We also talk of vagal blocks on the right side. There is something known as Aspire, which is like a PEG tube. You put that in, eat your food, go in the next room, open the valve and empty the stomach, and that way solve all your, get rid of all the calories. Again, the company has gone bust during COVID time is what I hear. It's in US. Other one is the Apollo endostitch, the overstitch, what we call, and this is probably out of all the endoscopic procedures, the most promising one. Again, briefly touched up earlier. What we do is endoscope, placate the stomach from inside, which reduces the capacity, affects the hormonal thing, and improves the weight loss. This is becoming popular, and recently, this is probably one of the papers which has contributed to it as well. Endoscopic sleeve gastroplasty randomized control trial from 9 centers in US. Mainly what to note here is that this is for low BMI patients, class 1 and class 2 obesity patients, and diabetic mainly. 209 patients, they noticed that excess weight loss at 1 year was up to 49%. Now, what we need here though is more long-term data. It also improved comorbidities, but we don't know yet. There is very limited data when it comes to 3 years and 5 years follow-up. So that's something to keep an eye on. Now, there are a lot of bariatric procedures, but probably worth just mentioning are the standard procedures, which are the IFSO endorsed procedures. As you can see in the graph, sleeve is the most popular. Band has declined rapidly in the popularity. Number 2 is Roux-en-Y, and OAGB, or what is known as the mini gastric bypass, has raised in popularity, and thanks to India was one of the countries which helped it grow and get recognized globally as well. So I'll briefly touch on what those procedures involve. Now, bariatric surgery, I think, how does it work? It's a complex answer here. I think we already touched on few aspects here. It's what is worth highlighting that it is a chronic and a complex disease, multifactorial. We always talk of restriction and malabsorption, but there are a lot of factors to it, including bile acids, hormones, gut microbiota. But again, I won't be going in more detail here. This is the trial, SOS trial, which started this whole journey of bariatric surgery. It is the longest study. And again, won't go in detail, but it's proved that bariatric surgery gave long-term good results compared to control group. All patients have to be investigated thoroughly by a multidisciplinary team, which is highlighted. So not just the surgeon, dietitian, physician, psychologist, physiotherapist, and a robust group to give safe outcomes to bariatric surgery. Talking of band, this is what a band looks like. So you put a gastric band or a tubing just below the OG junction, esophageogastric junction. There is a port on the anterior abdominal wall. You can put fluid in and you tighten it, and it gives you up to 40 to 50% weight loss. It is losing in popularity mainly because, as you can see, this is probably the most recent systematic review. There is high reoperation rate and high complication rate and weight regain issues. And therefore, it's now very less done in the world. So that's gastric band. Sleeve gastrectomy, probably the most popular operation at the moment. Technically very easy, restrictive plus hormonal and all effects as well. Patients can lose easily up to 60 to 80% weight loss, quite safe. However, the concerns with this operation are, and which is going to be closely monitored, is reflux and Barrett's esophagus, which is concerning. Other main issue is long-term weight regain. And because of that, new techniques are being developed. One of them is people are putting band on the sleeve to make it people lose weight and prevent weight regain. However, it has its own risks and problems associated with it. One anastomosis gastric bypass, now the third most common, technically easier operation. You make a long gastric pouch and bring 150 to 200 centimeter, depending on the BMI, and patients give good weight loss. We have published a lot on that, and it shows that it has safe, long and short and long-term outcomes. Again, reflux has been closely monitored. Risk of cancer has been mentioned in OG junction, but not that we have noticed of in this operation. Roux-en-Y gastric bypass. This once upon a time was considered the gold standard operation, where you have two anastomosis, a small gastric pouch, an alimentary limb, and a BP limb. Weight loss, excellent excess weight loss. When I mean excess weight loss, just for people who don't know, BMI 25 is normal. Anything more than that BMI is called excess weight, and that's what the excess weight loss mentions. There are loads and loads of paper mentioning that it is safe in long and short term. I think the Achilles heel for Roux-en-Y gastric bypass is internal hernia, marginal ulcer, and chronic non-specific abdominal pain, where there is no obvious cause found for the problem. So those were the standard procedures. There are a lot of other procedures which are what if so, name them as investigational procedures. Again, we won't have time to go through all, but SADIAS, SASI, SAGI, sleeve plus procedures, ileal transposition, sleeve plus bipartition. It is mainly different combinations of and different way, pylorus preserving, not preserving, measuring from the ileocecal valve, measuring from the ligament of threads. These factors given different names to these operations. Arun touched on this, so I will not elaborate. I think luckily with time as well. I think what we need to know is with bariatric surgery now, the term metabolic surgery is important and it is recommended now. This is what main it is. Class 1 obese patient with poor glycemic control, I think consider bariatric or what is known as metabolic surgery to help for safer outcomes. There are various scoring systems to assess and predict mortality, morbidity with these things, which are known as OS-MRS risk assessment or MMOS, and Cleveland Clinic has developed their own risk calculators. These are easily available on internet, and it is also worth having a look at them while you are having a consultation with your patient. So to conclude, my friends, I think we do have a dual epidemic of obesity and diabetes. The good thing is bariatric surgery is safe. It has good outcomes. For patients with less than BMI 35, as we touched on, endoscopy, balloons, ESGs, sleeve, and even short limb bypass are there. OAGB gives promising result in those ones. So I think that's something, and that's why maybe it's popular. Patients with high BMI, more than 50 or more than 60, sleeve technically easier, so becomes the first choice normally. But again, OAGB has shown quite promising results. Roux-en-Y bypass can be technically challenging in these groups. I think more and more nations are now adopting registries, so they will give us more of an idea. I think the search for ideal operation is still on, and the future is going to be a combination of different things, including pharmacotherapy, hormonal and stuff. And I think as a group, we really need to address this, or this is what probably will happen. So we don't need to mess it up. We need to start acting now. Thank you very much.
Thank you so much, Dr. Chetan. To continue with from where you left, I was of the opinion that UK has a registry which they publish to the public as well about the national outcome as well as individual surgeon's outcome, like what surgery is best in his own hands. Even though we have a lot of indications and a lot of results of each procedure, you also put across your national surgeons outcome of each procedure, and in your specific hands, what is the best surgery for different BMIs. So in your center, what is the preferred procedure for a given BMI as per your guideline, and explain about that national data registry, what they say about individual surgeons' performance and outcome.
Thank you, Raj. Interesting question. So our registry, yes, is open to public. Anyone can go on the website and click and look at the numbers. We do, compared to the obesity rates, we do say that we actually do less number of bariatric surgery in the whole Europe as well. We do around maybe 5,000 to 8,000, and we are pushing towards 15,000 to 20,000. We have written letters to the Prime Minister and the government, because this, as you know, it is funded by the government. We have a national health service, and the bariatric surgery here is funded by the government. So we want to increase that number in our national health service. Private is a different thing. It's not, again, not much supported by insurance. It is a self-pay system here. Coming to, so that is about the registry. It's transparent and open, including morbidity and mortality. Choice of procedure, we are a group of bariatric consultants in the hospital. I would say that since we started doing one anastomosis or mini gastric bypass, that has kind of become our procedure of choice. So even in low BMI, we are happy to do it. We alter the limb length. We start from say 120 up to 150. And then as the BMI increases, and maybe anything over 50 or 60 BMI, we would go up to 200. All papers show that going more than 200 becomes a bit, there are risks involved, because these patients are only followed up for 2 years in NHS. So we don't tend to do more than 200 centimeter BP limb. So yes, that's the first choice. However, if patient has history of reflux, there is a large hiatus hernia, or any other contraindications like Barrett's or severe esophagitis, then we tend to do the Roux-en-Y gastric bypass. For high BMI patients, BMI 50 or 60, Roux-en-Y bypass can be a bit technically challenging sometimes. In those cases, sleeve gastrectomy as an option. And again, smokers, we normally don't tend to offer bariatric surgery. They need to make some lifestyle changes for that. In high BMI, if you offer sleeve, there is an option of doing a, offering them a sleeve plus a second stage operation, either to a bypass, one anastomosis or a Roux-en-Y. If no reflux, one anastomosis is reflux or a problem, then Roux-en-Y gastric bypass. So that's our choice.
Thank you so much, Dr. Chetan. I would like to
We don't tend to do bands. We have done one band in 2 years.
Yeah, so band is gone out of picture most of the time. Yeah. And I would like to have Dr. Arnav Mohanty to give his remarks and conclusion as well.
Thank you, Dr. Raj. It was a truly enlightening session, and I would like to summarize in the fact that we should have a paradigm shift from the early days of bariatric procedures to a now modern concept of metabolic surgery. And like Dr. Chetan said, it is a combination in the future. It's going to be a combination of pharmacotherapy, probably endoscopic procedures as well, and probably tailoring of two-stage procedures to a single-stage procedure. We have gone full circle in many ways. We've considered sleeve in the beginning as purely a stage 1 procedure, and to be limited to those who are of a lower BMI, and probably with not so many comorbidities, and then reserve the RYGB to be a more physiological procedure, and then reserve it for the more difficult patient. But as more and more studies come forward and show that sleeve gastrectomy by itself as a standalone procedure, even in those who are morbidly or super obese, has had good effects, though long-term studies are yet to be revealed. The field is wide open, and with modern innovations and newer techniques and less morbid procedures, we are probably setting the stage for more early discharge procedures, more daycare procedures. And given this background, it's really a Pandora's box, which is opening up slowly in a fast rather. And I still feel that the hindrance as far as India is concerned is of a proper referral system where we would see more and more patients and counsel them and understand that the disease is obesity itself, like I earlier pointed out, rather than the comorbidities surrounding it. So thank you so much, all the orators, for highlighting all the points and starting from the um, problems around obesity and why diet fails and why exercise fails, moving on to the physiology of various procedures, and then considering the autonomy of patients, the logistic limitations, the indications, and finally all the procedures that are available. So I think we can move on to the question answer sessions. I can see one question in the chat box by um, Kirti, and she says that there is this patient who has had a bariatric surgery and has had a recurrence. I think the question is a bit open-ended. We don't really know what procedure the patient has had, when she's had a recurrence, and what is this extra body weight.
It was a
that
sleeve
she's lost.
gastrectomy with a BMI of more than 35.
Right.
That's what
So I think the first thing we need to do is go through the diet recall as to how things have changed when it comes to the diet pattern of this patient, the lifestyle changes. So it requires a little bit of an intensive history taking, what kind of follow-up the patient has had after surgery. Most of these people, one should be able to manage by correcting these areas. Some, after that, who still require any intervention, we could consider medical management. And finally, revision bariatric surgery is the last option. The reason I'm saying it's the last option is that most of the time, our hormonal and chemical mechanisms, which I had spoken to earlier, have already been exhausted. So revision bariatric surgery would not give the same kind of result as a primary bariatric surgery would. So one has to be careful in offering that and follow this process. I would like to know the opinion of our other panelists.
I think I strongly agree with you, Arun, and I can see that Dr. Kirti Singh has already posted that diet was not managed even post-surgery. So I think that is kind of self-explanatory, that needs to be addressed. And I think along with diet, we do under-recognize mental health, psychological and eating disorders. That is something which is going to be psychotherapy or revisional surgery.
Hello. Yes.
Yeah.
So, thank you, Dr. Chetan. Dr. Abhishek, any closing remarks from your side?
So, as we were talking about weight regain post-bariatric surgery, the first thing is we should, as everyone said, first we should understand why it happened. What are the actual reasons? Unfortunately, we have this temptation to jump on the highest modality available, which is revision bariatric surgery. But before that, we should understand that obesity is a chronic lifestyle disorder. No matter whatever you do, even if there is a small glitch, patient will again become, gain weight and have all these metabolic problems. So we have to have a very thorough investigation, a detailed counseling, detailed dietary history, any stress triggering factor which has occurred over this period of time, which has triggered weight gain, any episodes of depression or any antipsychotic drugs or any acute illness. So detailed history is of utmost important. And then depending on that, we can take a call whether lifestyle modification, re-counseling, or some behavioral modification or cognitive therapy or pharmacotherapy. And the last course should be, final thing should be a revision surgery. It should not be the first choice. It should be the last end choice.
Okay. So there is another question by Dr. Mala Mukund Bala. His question is, any role of our ancient wisdom of Ayurveda, meditation and yoga or pranayama, etc. in weight regain or weight loss? Dr. Arun Prasad, you can take this question up.
Definitely, everything has a role, and you know very well that obesity and bariatric surgery, morbid obesity, all these are terms which are of the recent past. When I was doing my post-graduation, I had not even heard of bariatric surgery. I had not heard of bariatric surgery even while I was in the UK. So these are all recent things. They are related to lifestyle, and lifestyle modifications are always going to be helpful. The modalities which you have mentioned have great role, and if only people were to follow these areas of traditional wisdom, a lot of problems in the current world, whether it is obesity or otherwise, would not be there. So I fully agree with you.
See, as I would like to add something to it. Definitely there is a role, but the problem is all these methods can be used as a lifestyle modification tools, but they cannot be treated as weight loss tool. This is what I want to convey. Exercise is good for keeping you healthy, but don't take it for granted that it will be a weight loss tool in long term. So it works if you're in the category of overweight, but if you cross that limit, if the margin is more, I wouldn't say that it is not possible. We have been seeing success stories, but 1 in 1 lakh, 1 in thousands will have that kind of motivation to reach that goal.
Agreed. So I would like Dr. Sushil to take over. Sushil Jain.
Yeah, thank you, Dr. Raj. So we have already overshot the time, so I'll take this quick opportunity to thank all the speakers, Dr. Abhishek, Dr. Arun, and Dr. Chetan, and also like to thank Dr. Raj and Dr. Arna for conducting this session. It was really a good overview over the bariatric surgery and the other aspects of the topic. And I thank all the speakers, moderators, and chairpersons on behalf of GAPIO. I'll also like to thank the IT team and the backend team who has made this possible to conduct this session, and so the participants who have actively participated and posted their comments on the chat box. Thank you, everyone, and look forward to more such informative sessions from GAPIO. Thank you.
Thank you all.
Thank you so much. Thank you so much.
Thank you, everyone. Have a nice evening. Thank you.
Thank you. Thank you, everyone. Bye.
Thank you all.